People are trickling in. Hi, everyone. Thank you all for coming. This is a great turnout. I think that we have some new people here. I'm just going to get started for the sake of time. I know Dr. Rubin has a lot to talk about. So if you're trickling in and you miss a little bit, I'm sure that you guys will catch up. My name's Aimee. I'm a med student at Loyola Stritch School of Medicine. So I know I have some other Stritch students here as well, but we've got people from Rush, Northwestern, all over the country. Dr. Rubin herself is from Georgetown. I'll go through her bio in just a second, but this is the Medical Student Forum. This is on female orgasms. So first, we would just like to say, we want you guys, it says here, save your questions for the end, but you can actually type them in the chat as you go. Dr. Rubin is really good about making things interactive. So if you have a question that's burning on your mind, just go ahead and pop it in the chat. We would also just like to acknowledge that while this event has a large focus on the experiences of cisgender women, and at times during the event today, you may hear the terms woman and female used to refer folks with vulvas and vaginas. Transgender women are women regardless of their surgical status. And also, if you guys could just mute yourselves, so sorry. We recognize that not everyone who has a vulva or vagina or who was assigned female at birth is a woman, and there are also women who do not have these body parts. Therefore, at the forum, we do our best to speak about vulvovaginal conditions in gender-neutral terms when not referring to cisgender women in particular. Next, I just want to introduce you guys to our forum president, Jen Romanello. She's just going to tell you guys a bit about what we do here.
Hi, everyone. My name is Jen Romanello. I'm a med student at Rush, and the Medical Student Forum on Female Sexual Medicine, this organization, also called the Forum. It's an independent medical student-led organization to facilitate med students to collaborate, learn, and educate academic peers about female sexual medicine and dysfunction. So there are a variety of medical conditions addressed by this field. Yet such information is
now we gotta say we're talking about cisgender.
But such information is typically underrepresented in med school curricula. The term female sexual medicine encompasses issues with arousal, problems with orgasm, pain with sex, low libido, causing distress for patients. At the forum, we've conducted curriculum reviews and published on the inclusion of female sexual medicine topics in med school curricula, as well as created independent panels, lectures, discussions, and connected students to research and mentorship opportunities. We've also created 2 annual symposiums each January, featuring experts in the field. Students on our leadership team have come from all 7 Chicago area med schools, and medical students from schools around the country have attended our events and participated in creating our program.
Awesome. Thank you, Jen. So that was our wonderful forum president, Jen, and founder. So before I let Dr. Rubin speak, I just want to tell you guys a bit about her. So Dr. Rachel Rubin, she's a board certified urologist and sexual medicine specialist. She's only one of a handful of physicians with a fellowship training in sexual medicine for all genders. Dr. Rubin is a clinician, a researcher, and very passionate educator. In addition to being education chair for the International Society for the Women's Study of Sexual Health, or ISWISH, as you guys may know it, she also serves as an associate editor for the Journal of Sexual Medicine Reviews. Dr. Rubin completed her medical education at Tufts University, her urology training at Georgetown University, and her sexual medicine fellowship training with Dr. Erwin Goldstein in San Diego. Dr. Rubin is passionate about providing comprehensive care to her patients. She views the role of a physician as more than someone who offers diagnoses and prescribes treatments. She sees her role as a coordinator of care for her patients to help them achieve their sexual health goals and improve the quality of their life. She also is passionate about educating her patients, hoping to empower them to take control of their own health and advocate for better care. Early in her medical training, Dr. Rubin recognized the limitations of the current healthcare system. In a 15-minute visit, she could not even hear her patient's entire story, let alone have a conversation that allowed her and the patient to come up with a care plan based on that patient's goals. She launched her own practice in 2022 so that she could provide patient-centered care with a multidisciplinary approach. She works closely with physical therapists, sex therapists, and other medical and behavioral health providers. In addition to her practice, Dr. Rubin serves in an active role in several medical societies and frequently speaks at conferences. She considers it her responsibility to educate other providers to ensure that they are armed with the tools to provide evidence-based, compassionate care to their patients. Dr. Rubin is also a frequent guest on webinars and podcasts and has been interviewed by journalists for a number of publications. She is also an advisor for this forum. So without further ado, I'm going to stop sharing my screen and I will hand it over to Dr. Rubin.
Oh my goodness. Okay, you all, it is September 1st. It is 8:30 p.m. on the East Coast. My kids just went to bed and there are 115, now 16 people on this freaking Zoom. Can you just believe that? I mean, for a second, you are choosing to be here. Holy shit balls. Like, you are choosing to be here. I'm wearing my forum t-shirt. If you are not a part of the forum, get involved. They'll put all sorts of information, hopefully, in the chat on how to get involved, how to learn about it. We need to create a movement. We need to create a movement of pissed off people who demand better science, better medicine, better education, and just everything better for all humans. Like, this is not like a gendered thing. This is a we suck at sexual medicine for all genders, for everybody. And so I am just like, I can't even, right? Like, now it's 119. I'm just going to watch how many people come on. I'm not going to speak at all. Like, what in the world? So I want people to go in the chat box and tell me, I want you to just say if you're a medical student here or a student, say where you're from, what year you are, just to get a sense. I know there's a lot of non-medical students here. Some of my friends have snuck into these Zooms. So of course, friends, hello, I'm so glad you're here. We've got Chicago, Ohio. I was born in Ohio, for anyone who doesn't know. Miami, Buffalo, South Carolina. It's going too fast, you guys. I can't even see. California. We got a DC in the house. Virginia. Holy shitballs, you guys. Like, we have California. You are all like, if this doesn't make your eyes tear up and well in excitement, like, I don't know what is. And this is the whole point. I want you all to understand that you can change the whole gosh darn world. You specifically can change the whole world. So I want to tell you a very quick story. I'm a storyteller. I think that's why it's effective. So I was just in my clinic one day and this little not even gap year student shows up into my office out of nowhere and just says, Dr. Rubin, can I come shadow you one day? And I said, sure, why not? Anyone can come spend time with me. And she spent time with me and she came in. And by the end of the day, she had rearranged my entire office. She had organized it in a way that I didn't even know it needed to get clean because I don't know how to do stuff like that. And by the end of the day, we had just learned so much from each other, she from me and me from her. And she then went off to medical school and started this female sexual medicine forum. Like, she started an entire group and this entire organization that has a huge number of members that is now spanning across all many medical schools. And she is going to change the whole gosh darn world. So Jen Romanello started this group and it has grown into I am so proud of these students. I'm so proud of all of you for just showing up on the Zoom. And like, this happened to be like an inspiration thing that she found and she was able to sort of create with the help of her peers. And so I actually was inspired by Jen Romanello for doing this. And I have started to work with the students. I'll be honest, you guys, I didn't have good mentorship when I was in medical school, even in residency, to be honest. It took me really until my fellowship to find people who really truly cared about me and who I cared about what they were doing, who cared about the things that I cared about. I didn't know my people. I didn't find my people really until fellowship. And so I want differently for all of you. You don't have to care about what I care about, but I want to help you feel cared about. I want to help you feel loved. I want to help you feel heard and seen. And so any way that we can connect you with people who do that, and they may not be at your institution. I'm going to share my screen. I'm going to, anyone who knows me or hears me speak, like I could talk for hours and hours and hours. So I promise, I know you're here to hear about orgasm. So we will definitely talk about orgasm. Aimee, can you see my slide like in the regular slide way? Okay. So I want to just be very clear. So I never had good mentorship. And then it was until my fellowship where I met Dr. Erwin Goldstein and his wife, Sue Goldstein, and I am forever indebted to them. They are the father and grandfather and grandmother of sexual medicine. They are wonderful. And they started this organization called ISWISH, the International Society for the Study of Women's Sexual Health. And anyone who's on here, tell me if you're a member of ISWISH. There's 130 people now on this Zoom. Tell me if you're a member, because students get free membership to ISWISH. And it is an organization, a multidisciplinary organization that is entirely devoted to furthering the science, education, and advocacy of women's sexual health. So join. You might as well join now and find your people, because if you are on a Zoom, I swear to God, you guys, if you are on a Zoom on a freaking Thursday night at 8:40 at night and you care about the female orgasm, these are your people. Like I think there's 100% certainty that these are your people. So you all have to join this organization. There's no questions. If you do have questions, let me know. I am very biased as I am the education chair of this organization. And something else that we've done, if you really do have an interest, we have started what's called the Sexual Medicine Research Team, and it's grown even bigger than this. We need to get updated pictures and headshots. And it really came from me wanting to I'm so tired of telling patients there's no data for this. Sorry, there's no data for this. There's no data for this. Well, we just don't know. We have no data for this. So let's freaking collect the damn data, okay? Let's find ways to make collaborations to work with people and just demand the data. We are eventually going to find rich people to help fund our data. We're going to apply for grants. We're going to do so many things. We just submitted a bunch of abstracts to the Sexual Medicine Society of North America. I think we had 5 accepted. We had podium sessions, oral presentations accepted. It's just a group of students from all across the country who meet the first Sunday of every month at 8:30 p.m. If you are invited, it is not a selective group. And we just collaborate. We talk about projects we're interested in. I don't know everything. I don't know how to do an IRB. I don't know how to do statistics, but I have a lot of friends. And I've learned that you don't need to know how to do everything to do something. And so if you are interested and you do want to hear what we have to say and you want to learn more, please consider joining. There's an email there. You can email to get involved. So who's excited? Who has learned something already? And this is an example of one of our Zoom calls. We have a lot of fun. We are not meeting this Sunday because of Labor Day. We're going to meet the next Sunday. So just to give you an idea, I bring in some guest speakers sometimes. We've had amazing time. Who comes to these smart meetings? Any of my smart people on? Say hello. Go in the chat box, you guys. I have to make this interactive. Woohoo. See, look at all those cool people. All right. So tell me, we just said we have med students here from all over the country. We've got M1. We're going to mute everybody who's not muted. We've got M1. Oh, maybe not. I can't find that person. We've got M1s, we've got M2s, 3s, 4s, PAs, NPs, nurse practitioners, doctors. Who learned about the female orgasm in medical school? Did anybody? Does anyone? Nope. Asked to, was denied. Oh, I love that. We will not teach you about the female orgasm. That's it. We're going to get 3 responders, barely. Oh, Pritzker had one slide in med school in Olivia's dreams. If you don't follow Olivia on Instagram, you should. She's pretty great. Not me. I'm in my sex repro block right now. I'm not hopeful. Honestly, don't expect to. We haven't had repro yet. It was not good. Rush was amazing, but that's probably because Jennifer Romanello made them. Never heard of pleasure. Not yet, but we haven't had repro yet. So you guys are close to this, right? Like you are going to see what you learn and what you don't learn. And you can start asking questions. You can start demanding things. Like people don't like when you ask questions, but do it anyway, right? So I really believe that you cannot diagnose what you do not. You can't diagnose what you don't look for, people. If you don't know about it, you literally cannot find it. And we're finding that in sexual medicine, right? If you don't ever examine the clitoris or the vulva, you will miss pathology 100% of the time. And so we know, who's heard of the pay gap? Has anyone heard of the pay gap? Yeah, hell yeah, right? Like we get paid so much less. I get paid so much less than my male urology friends, but that's why I started my own practice, because I was like, I don't want to have to deal with the pay gap. I'm just going to do it myself. So there's a pay gap, right? Women are paid a lot less than their male counterparts. Well, there's also an orgasm gap. There's a very significant orgasm gap in the country. So I very much believe in pay equality, but I'm also on a mission of orgasm equality, right? And we're going to talk about that. For every orgasm a heterosexual man has, a heterosexual woman has 66% the number of orgasms, right? So is really, it's not good. So today we can talk as much or as little as you like when it comes to, we'll talk about epidemiology, anatomy, physiology, workups, and treatment, and I'll try to be as interesting as possible. It's kind of interesting, the definition of orgasm. Like if you were to write on a piece of paper and say like, well, what is an orgasm? Like what is, it's like, you know, it's like one of those things like pornography. I know when I see it, but it's really hard to, you know, it's hard to define. And so what's cool is ISWISH actually tried to define it. They actually got a group of people together and they made them sit in the room together and they said, okay, people, it's time to define the female orgasm. And here's the crazy story. One story that I will hope to tell for the rest of my life. And I took a picture because I knew how amazing it was going to be. I was traveling to San Diego, visiting where I wanted to do fellowship with Irwin Goldstein, my mentor. And it was I was there the exact week that they were defining the female orgasm. And it was these two old white Jewish men who were defining the female orgasm. Now, before you get all upset of like the patriarchy and all the glass ceiling and all of these things, these are the two most incredible men in the history of the universe when it comes to understanding, care about, researching like ultimate he for she in the world, lovable humans, and they were responsible for defining the female orgasm. And so I literally was a fly on this wall. I was standing there and I just said, oh my God, I have to remember this moment for the rest of my life. Like this is going to be the best story ever. And so the guy on the right is Barry Komisarek, who is a neurophysiologist at Rutgers, who has spent his career as an academic neurophysiologist understanding the female orgasm. He does all this fMRI research. He puts people in brain scanners and has all this orgasm research. He is the smartest, kindest, most incredible man you'll ever meet. And the guy on the left is Irwin Goldstein, who he was the first author on the Viagra papers in the New England Journal of Medicine. He was a huge, he's a pioneer in male sexual medicine. And it was when Viagra came out that all the women started calling him when he was at BU and said, Goldstein, what do you got for us? And he says, we have nothing for you. And so he basically created the field of female sexual medicine in 1998. He created ISWISH. He has been a pioneer in supporting women's sexual health. So before you get mad that the men were defining the orgasm, these guys showed up, right? They showed up when nobody else will show up. And so what did they say? So they said, so this is like a mouthful, everybody. So an orgasm in women is a variable, transient peak sensation of intense pleasure, creating an altered state of consciousness, usually with an initiation accompanied by involuntary rhythmic contractions of the pelvic striated circumvaginal musculature, often with concomitant vaginal, uterine, and anal contractions, and myotonia that resolves the sexually induced vasocongestion, sometimes only partially, and myotonia generally with an induction of well-being and contentment. What is your gut when you read that? Like, ain't nothing sexy about that definition, but like, what do you think? Give me your gut. What's your gut when you read that? Someone be brave.
My first reaction was altered state of consciousness. What does that mean?
It's like a seizure, right? Like orgasm is like a seizure, right? It sounds complicated, very medical, complicated. Sounds anatomically accurate, I guess. Like society is trying to complicate it or make it very medical, leaves a lot of room for a variety of experiences, right? It's super interesting. But I love how medical it is because orgasm is so often not medicalized, right? It's often thought as magic, that orgasm is magic. So there is a lot of women on this call right now, probably a lot. And I don't need you to go to the chat boxes to tell me, but I want you to think to yourselves, has a doctor ever asked you if you could orgasm? Me, nobody's ever asked me, right? Never, right? Oh, you guys are so brave going to the chat boxes. I just love you all. So no one has ever asked me that question. And everyone knows what I do for a living, because as you can tell, I talk about it nonstop because it's pretty cool. And I don't have any hobbies, so that's pretty cool. And so we're not asking. We're not talking about it. And when we do that, so who's in charge? Who is in charge of orgasm besides obviously ourselves, but who is in charge when something goes wrong, or when there could be medicine behind it, or we give medications or do surgery that can affect and change orgasm? Because I'll tell you, patients are pissed when things go wrong and they're mad, and they go to the doctor and they are told that they are looked at like they have 6 heads. And that's a big problem. But orgasm problems are pretty common, right? So this is actually very interesting. It's an interesting thing about epidemiology and female sexual medicine is we talk about how common a problem is, but then we ask patients if they're bothered by it. So if you have low libido, but you're not bothered by it, it's not a medical problem. If you have an orgasm problem, but you're not bothered by it, it's not a medical problem, right? I've got wrinkles in my forehead. If I'm not bothered by it, I don't need to put Botox in my forehead, and I choose not to. And so orgasm, probably about 20% of women will identify as saying they have an orgasm problem, but only about 5% are bothered by it. And I don't know what the answer is there. Is it because they don't think that there's a solution? They've just had the problem forever. So this is just the way life is. Why should I be bothered by something? And so it's kind of interesting. We also know that it's very common. Let's see what we hear. Age, distressing desire, orgasm. Here we go. So how distressed are patients by it? Well, when you get to the 45 to 64, right, you get these distressing, patients seem to get distressed. And 65 and older, 5% are distressed. And many medical problems can lead to sexual problems. So this idea that only Rachel Rubin can do sexual medicine is absolutely insane. I need all of you to go into all of your fields. I need my GI doctors. I need my oncologists. I need my radiation doctors. I need my radiologists, pathologists. I need every single one of you to go into something different. And I need you to give a crap about sexual medicine, because everything we do to patients, in fact, if someone can even think of a field that doesn't have to do with sexual medicine, I want to hear about it, because I just can't think of one, right? That has absolutely nothing to do with sexual medicine. So if you never learn about it and you go into all these fields, like there are patients that you see every single day that have sexual problems. I tell you, I had a guy in my clinic today. He had diabetes, high blood pressure. He was overweight, right? And he had no erections. And so how can you help him to understand that his medical problems are the reason why his erections aren't working, right? And so you have to understand how every medical condition, every medical problem can lead to certainly orgasm, libido, arousal, and pain conditions. So back to our orgasm gap, they asked many thousands of people of all sexual orientations about the last time they had a sexual encounter. How often did they have an orgasm? Okay, so for heterosexual men, so hold on, men's over here. Heterosexual men, you have always or usually 95% of the time. Gay men, you have 89% of the time. Don't make me do math. And then if you have heterosexual women here, you've got about 65% of the time. Okay, it was a little better when you got into bisexual and lesbian women. So we know that, right? There's some data out there that shows if the first sexual encounter that you have, if a woman has with a woman, she's got like a 90+ chance of having an orgasm. If the first sexual encounter is with a man, it's like 6%. I don't remember the number, but it's like in the single digits percent that the first sexual encounter, she's going to have an orgasm. And so it matters, right? It matters. This orgasm gap matters. So why don't heterosexual women value their orgasm the way that heterosexual men do, right? And there's many reasons for it. I'm not going to go into a psychosocial history lesson here, but I want to talk about the answer through anatomy and physiology, because I think that can help explain at least some of it, maybe not all of it. And it really has to do with also sex education. So we're going to play a game. What do we call it now when we ask med students questions? Is it still, it seems like not appropriate to say the word I was about to say. Is that still what they call it? Yeah, okay, I'm not going to say it, but all right, quizzing. I'm going to quiz medical students. I love it. So I'm just going to quiz you. So live in a world where everyone is heterosexual. That sounds like a terrible world. I don't want to live in it, but let's live in a world where everyone is heterosexual and we give every heterosexual man in the world a stopwatch. And as he presses on, he enters his female partner because, it's all this heterosexual world. He penetrates his female partner and then he clicks the stopwatch off as soon as he orgasms. And there's a medical term for that. It's called IIELT, ejaculatory latency time. I don't remember what the other I stands for, but okay. So how much time goes by on the stopwatch on average? If you've heard me say this before, which I've spoken about this many times, so that don't answer, but give me a time. Be brave, put in the chat box. How much time goes by on the stopwatch? 7 minutes, 3 minutes, 2 minutes, 1 minute, 3 minutes, 5 minutes, 10 seconds, 2 minutes, 20 seconds, 3 minutes, 5 to 10 minutes, hedging there, 60 seconds, 30 seconds. Oh, I love all your answers and your bravery. 2 minutes. I love you all. Can you believe, oh my gosh, you guys, this is now 149 freaking people on a Thursday night. Jen Romanello, I'm dying. Okay, answer time, 5.5 minutes. Okay, 5.5 minutes. And it's a little bit variable. This data came from Marcel Waldinger, was a wonderful researcher. He did a lot of studies on premature ejaculation, and he did a lot of the studies on post-orgasmic illness syndrome. He sadly died a couple years ago. And so we're actually trying to help get more research on post-orgasmic illness syndrome and help with his legacy. Many of the students in this group are actually helping us with that, which is extremely cool. So 5.5 minutes, right? If you give people a stopwatch. And so it's a little different depending on what country. I think the US, it's about 7 minutes because we're amazing, right? The USA is incredible. And in other places, maybe more, maybe less. Okay, so let's switch gears here. Are you guys learning something? Can I get a yes? I got a thumbs up from Natalia. She's super into this. All right, some of my boys on the group is saying yes. Woohoo! All right, 10% of you are going to hate me, just so you know. I will get hate mail from 10% of you, and I'm okay with it. I'm here for it. So, okay, let's switch it up. All right, let's go same heterosexual world, but now the tables have turned and we're going to get that stopwatch into all let me go back to my stopwatch to make you get excited. We're going to, hold on. We're going to give that stopwatch to all the ladies. Okay. How much time is going to go off for her to have an orgasm with her incredible, wonderful partner, who is so supportive and really wonderful? 30 minutes, 20, oh my God, you guys are so fast. 20 minutes, 2 hours, 15 minutes, 25 minutes, 45 minutes, still waiting. I love you, Kristen. 30 minutes, 20 minutes, 12 minutes, 20 plus, 18, 1.5 from penetration. LOL, never. You're amazing also. 45 minutes, 19 minutes. I love all of those answers. This is so good. Okay. So this study actually was done very recently. Again, it's not the best study in the world in terms of how it was done. And I actually think we could probably recreate this study better. I think you all could redo this study on a grander scale and actually get good data. But let's look at it. So in April 2020, it was published in the Journal of Sexual Medicine, and it was called TITOR, or Time to Orgasm in Women in Monogamous Stable Heterosexual Relationships. So if we go to United States in there in the minute, it was about 13 minutes, plus or minus 7.6 minutes. Now, but let's look a little closer. 17% of the participants had never experienced orgasm at all. And penovaginal intercourse was insufficient for the majority to reach orgasm. Okay, why, people? Anatomy. For goodness sake, it's anatomy, right? Why would women orgasm from penetration? It doesn't make any sense, right? I actually have a theory behind it, but it is like telling a man, if you rub the inside of your thigh over and over again, you should orgasm easily. Like, it's not going to happen. So here, apparently, if you live in the Czech Republic, you can orgasm in 6.8 minutes. But if you live in Hungary, it takes 22 minutes. It's fascinating data. You can't make it up. But these numbers were pretty small. So I don't think that this was like it's not like a great study, but it's very fun to talk about. We have even better data from the wonderful Debbie Herbenek, who is from the Kinsey Institute. If you don't follow her stuff on social media or in general, she's incredible. And she talks a lot about how it's really, most women do not orgasm from penetration. While 18.4% of women reported that intercourse alone was sufficient for orgasm, 36.6% of those reported that clitoral stimulation was necessary for orgasm. So for most people, they're never going to orgasm from penetration, and the ones who can still kind of require clitoral stimulation, except for those ninja unicorns who are so loud. So if you're sitting here on the call and be like, what are you talking about, Rubin? I have like the most magical orgasms ever when someone just looks at me, and you enjoy that, you're very lucky. Everyone's jealous, and stop being so loud because you make all my patients think that they're broken. They're not broken. You're just magical. So I'm all for people like being magical, but we have to understand the data. What does the data show? And also understand what is the freaking anatomy, right? If like, how will people, it's like, what is the anatomy? So let's talk about it. Oh my gosh, you guys, I'm going to talk forever. So I'm going to try to go a little bit faster. This is how I break down the anatomy of orgasm. And what's fascinating is still in 2022, there's so much we don't know. The ISWISH is actually putting together an entire panel of people to kind of try to figure out the female orgasm, which is very cool. So the more you get involved in ISWISH, the more you'll hear about this panel, kind of continue to learn more about orgasm. And so like everything, I actually think you can do most sexual medicine using this picture and just switch out a different genitalia for the last picture. I think you can really say, okay, what part is happening in the brain, what's happening in the spinal cord, and what's happening in the genitals themselves. And so it is this whole body thing, right? It cannot just be just gynecology or just psychiatry. Like it's the whole body thing. It's a reflex, it's pleasure, it's a muscle contraction, it's musculoskeletal, it's neurotransmitter, it's hormones. It's everything. And that's why everyone sucks at it, because nobody is good in medicine about doing all the things. I'm certainly not. I just, I have a lot of friends that I like to ask questions and I'm interested, but by no means am I good at it. So we know the homunculus, right? There's like a big genital part of the homunculus, which is like right by the feet. So some people really like foot stuff. We know like nipple stimulation can be really exciting for people. And people can have orgasms from nipple stimulation. There's so many different ways people can describe orgasm. We know that so many things go into this, right? Dopamine, testosterone, estrogen. We know antidepressants can sometimes really slow down orgasm or stop it altogether. I have a lot of very grumpy patients who have trouble orgasming. And so there is so much that goes into this, positive and negative, right? We know norepinephrine and oxytocin and all of these things, it's like it gets very confusing and kind of understanding these things. And so we can play with all these things. We have medications that can alter all of these things, but you have to think about it. You have to think, where is the problem? What's happening? How do we have it? And orgasm problems are very difficult to treat because are they not educated and trying right? Is it an education problem? Is it a clitoris problem? Is it a reflex problem, in the spine? Is it a brain problem? Like, what is the thing? Whereas we as a society right now, if you go to the doctor and say, I can't have an orgasm, they send you right to the sex therapist. It must be your religious upbringing. It must be trauma. And there's so much medicine and science that could go into this of like just like saying like, oh, it must all be trauma is not really helpful. Yes, I'm happy to share anything with anybody as long as it means you learn and you help other people. So when it comes to the spinal cord, right, we think a lot about sort of parasympathetic and sympathetic nerves. Everyone loves to talk about the pudendal nerve. Like it's all pudendal all the time. And it's not just the pudendal nerve. The pelvic nerve is so incredibly important, right? Pelvic nerve is what's responsible for the arousal of the penis. Why wouldn't it be responsible for the arousal of the clitoris? They're the exact same organ. So why don't we just read the textbook of what it says about penile innervation and just copy and paste it where it comes to clitoral innervation, because it's 100% the same. And so the pelvic nerve is really important. There's one place that's super fascinating is the cervix. Okay, some of you on your OBGYN rotations right now, ask every OBGYN you come in contact with, what's the nerve? Actually, don't do this. They'll give you a bad grade because you'll be like fighting them. But like ask them, what is the neuroinnervation of the cervix? And they'll probably tell you the cervix has no nerves. Not only does the cervix have no nerves, the cervix is triply innervated. Very commas directed, this work. It is innervated by the hypogastric, the pelvic nerve, the hypogastric nerve, and the vagus nerve. This is why some women with penetration feel nauseous, is because you're pounding against that vagus nerve and they have like nausea. Actually, had a doctor text me just yesterday or the other day saying I have a patient with nausea. So I told them to use an O-nut, which is sort of a bumper cars for the penis so that he can't penetrate fully and too deeply. So maybe he won't hit the cervix. So it's pretty cool, right? Like play around. I don't know if it's going to work, but why not try it? So very interesting, right? So this idea of the sympathetic and the parasympathetic and which piece is arousal and which piece is orgasm. I mean, orgasm is fascinating because you have this like super duper time between the parasympathetic and the sympathetic where you're having this increase in blood pressure, this increase in heart rate, and yet you also need this relaxation and this vasodilation. I mean, it really is like running a marathon and having a seizure all at the same time. It can be very exhausting. And what about the vulvar anatomy, right? We all start the same way. God, this picture is the most important picture in Netter's that is wrong. It's just wrong. But right, Netter's, like, I love it, right? You start the same way. The homologous structures are so important. The one place he gets it wrong is this part that's brown and unlabeled should be pink. Okay, the labia minora should not be pink, but the brown part here, does anyone know, none of you who actually know, and if anyone knows from me, don't say it, but like, what is this brown tissue that surrounds the urethra up to the hymen? What is it called? You are 3 correct answers and 3 very brave humans. You got it, Ruxy. No need to question yourself. You're amazing. So, right, the vulvar vestibule. What's crazy is if it's pink, let's go over here. What's pink? What's this? What's this, guys? Come on, someone be brave. It's a tube that man pees through. It is called starts with U and ends in urethra. Oh, Rebecca's got it. Chelsea's got it. You guys are awesome. The male urethra, right? It's urine. It's your bladder tissue. It's the extension of the bladder. So the male urethra is the same as the vulvar vestibule, which is bladder tissue. That's not for this talk because I know we're talking about orgasms here. The head of the penis is the same as the head of the clitoris, for goodness sake. The shaft of the penis, all right? Like, you guys know this picture. I'm sure Jen Romanello has posted it everywhere, all over your med school and all the bathroom stalls and all of those things, right? The penis is a big, huge structure that goes all the way down to the butt bones. For anyone with a penis on this call, kind of put your butt back and forth and you feel those bones, right? Your penis attaches to those butt bones. You've got these long legs, these corpora cavernosa, these erectile bodies, half of it's outside, half of it's inside. Well, the clitoris is exactly the same. It's just that like 90% of it is inside, right? But you have the same, you guys can rock from side to side. You're sitting on your clitoral bodies. It's the same erectile tissue. It's the same smooth muscle tissue. If we cut them in half, they look exactly the same. Top one's a clitoris, bottom one's a penis. The only difference is the men have the urethra, and it's a little bit bigger because they are hopped up on 10 times the amount of steroids that we are, that I am, that steroid being testosterone, right? And so testosterone is the thing that like grows the thing. So it's the same tissue. In fact, if you take a clitoris, I mean, these cadaver dissections are just like bananas. Like the clitoris is this giant thing. If you, for anyone who goes into urology, and you should all go into urology because it's awesome. If anyone goes into urology, right, this is like, if you ever do pediatric urology and you do a hypospadias case, like this is what the anatomy looks like. Like this is, it's like, it's just so fascinating. Okay. We could talk anatomy all day long, and there's so much about anatomy that I don't even know, right? Which is so wild. So don't feel bad if you don't know stuff. Pelvic floor, right? The muscles have to contract and relax and like orgasm and spasm and all of these great things. What if you have a condition where your muscles are not working well, right? Or what if your muscles are so tight, like all you damn med students that are so stressed all the time, because how could you not be? By the way, I just want you all to know, I have been out of medical school for, I don't even want to say how many years. And it was only this week that I had a moment where I sat down and I said, holy crap, I'm not in survival mode anymore. It took it's been what, 6 years after my residency? It's been 6 years since residency. And for the first time, I was like, oh my God, I'm not surviving. I'm like living. This is like the difference between survival and life. And I have to learn how to do it because nobody ever taught me how. And so I've been wearing the wrong size shoes for 5 years, over 5 years since I had my daughter, right? Because I didn't know that I needed to like change my shoe size. I literally don't know how to live life. So if you're impressed with me, don't be. Try to like live while you're in survival mode. Just so you don't be like me, try to like live life while you're doing this, just so you know. So those muscles, if you guys are so stressed in your muscles, and men, you have this pelvic floor too, you can just get the same pelvic floor problems. If your muscles are so tight and they're up here, how are you going to build up and release tension and have a great orgasm? It's going to be challenging, right? So it's really important. So what are things that we find on exam that could affect orgasm? Well, the SMART group published a paper. They wrote the whole IRB. They collected all the data. They spoke to all the patients. They did all the statistics. They wrote up the paper. They submitted to the Journal of Sexual Medicine, and they got it published. Open access. You all could Google it and read it now. But they found that in clitoral phimosis, that if you take away the clitoral phimosis, you can improve orgasm, arousal, and satisfaction. Incredible. Your group, your students, your peers did that. I've never been prouder in my entire life. There's the link to the article. Read it. And it's my proudest work, and I did none of it, right? You all did it, which is the coolest part of it. If you have someone over 50 or 45, they may have hormonal reasons or something called genitourinary syndrome of menopause, where hormones affect their ability to orgasm. Okay. I know we're still talking anatomy here, but all sorts of things can go into orgasm. Nipples, earlobes. Some people like thigh stuff. Apparently that's a thing. Flushing skin. Other critical components, right? Clitoris, pelvic floor, all of those things. So are you guys learning something? Is this helpful so far? I mean, you guys have to go to bed soon because you have real important things to learn. Oh my gosh, they're still awake. They're still awake. And look, there's 151 people still on the call. That means nobody has left to watch Shark Tank, though I encourage you all to do so because Mark Cuban cares more about women's sexual health than any doctor I've ever met in my life, because he is making vaginal estrogen affordable and for cash. And he DMs me regularly to give me updates about it, because he understands that this is important, because I tweet about it and someone told him that he should know that I care about this. One person, right? One person, me, just loud on Twitter, and Mark Cuban being like, "Ooh, I got to tell you about my vaginal estrogen product." Seriously, guys, hold on. I'll show you. It's your true story. I'm not bragging. I'm just bragging. I'm bragging. I was on the couch with my son who had COVID watching a Disney movie, and it was like, Mark Cuban has sent you a direct message. Yeah, that guy, Mark Cuban, right? He's messaging me about vaginal estrogen, and he continues to message me about vaginal estrogen. The only conversation we're having is about vaginal estrogen. Unbelievable, right? Unbelievable. Mark Cuban, vaginal estrogen. Just let that sink in. One person. You can do this. I am not special. You can do this. Like all of you, find the thing you care about and just keep doing it, keep doing it, keep doing it. Don't stop, get loud. Don't give a crap who comes in your way. You will find your people. Okay. Sorry. I just had to go on that rant for a second. So what can go wrong? So many things can go wrong. Everything can go wrong in medicine, right? Where's the lesion? The lesion can happen anywhere. So what do we see? We see all sorts of FODs, or female orgasm disorder. So there can be problems with distressing in the frequency, in the intensity, in the timing, in the pleasure. All of those things can go wrong. We can see too many orgasms or persistent genital arousal disorder. We can see muted orgasms. We can see weak orgasms. Anorgasmia is so challenging, right? I never had an orgasm and I lost my orgasm. And how do I get it back, right? I had a woman come in and said, Rubin, I used to taste color when I had an orgasm, and then I had a baby and I can no longer taste color and I am pissed. And I was like, ma'am, I too would be pissed if I could taste color when I orgasm, and I also would want it back. So welcome to my office, but I don't have any, I have no magic. But right, pelvic floor, like what can we do for her, right? And how can we work it up? What's the workup? And just like we said, right? Brain, spinal cord, genitals, and pelvis. Work it up, right? Work it up from top to bottom and understand. So this is within your grasp. You don't have to know anything to do what's the most important thing, is take a good history, right? Never allow yourself. You guys are going to go into the clinics, and many of you are already in the clinics, and some of you are already practicing practitioners. And in 10 minutes, like, you're just not going to get to what you want to get to. And it's not acceptable to just think that people are 5 minutes worth of like you do not figure someone out in 5 minutes. And you can be okay with that. I'm not saying like you can't be okay with that, but like, if you care about, if they're bothered by something and you're not taking that good history, you're going to miss something. And don't ever listen, like, don't ever say that in your brain, oh, this person is crazy. There are crazy people out there, right? There are, but always assume that you are not figuring it out because either you don't know, you haven't asked the right questions, or the system is so broken and on fire that like it's not allowing you guys to figure out what's going on. Ask a bajillion questions, right? Find out what's going on. Get that good sexual history. Do not be afraid. Y'all haven't even ever been asked, right, if you could have an orgasm, let alone how do you orgasm? How do you have sex? What kind of sex do you want to have? What seems right for you? What seems to give you pleasure? Do you know where your clitoris is? Do you have this? Let's get a mirror, right? Like, could you ask? So the more you ask and the more you get comfortable asking, the better it's going to be, the easier it's going to get. Because I tell you, I do this all day long, and I'm not afraid of anything, right? People come and tell me anything. I don't get shy. I don't get blushing, very rarely. And people feel comfortable in my presence just because I show up and I care. It's not because I'm a genius. It's because I show up and I care. All of you can show up and you can care, right? And you can ask, because no one else will. Literally no one else will. So I encourage you, don't think about, how to ask and what exact questions do I have to, just practice with your friends, talking about sex, making it normal. These are just body parts. They bleed, like literally vaginas bleed once a month. Talk about it, right? Literally vulvas, like normal body parts. They should not bring disgust or shame. Like, they bring pleasure, they bring joy, they bring babies, they bring pleasure to everybody. Why are we talking about them like they're shameful body parts? If you have a bloody nose, or you're going to be embarrassed going to the ENT, right? Like, it's crazy the way we treat genitals. So talk about it. Get used to talking about it. Don't dance around the idea. Like, if you're uncomfortable and weirded out by your own genitals, how do you think your patients are going to feel? And how do you think you're going to show up to those patients, right? If you make it weird, they're going to make it weird. And that's what the data shows over and over and over again. We're down to 149, you guys. We've lost a couple people. So I could go on and on and on. And there are lots of resources out there. And there's lots of devices and vibrators and fun things that we can do. I'm going to do one more pop quiz before, and I'm happy to show some more slides, but one more pop quiz. What is the number of FDA-approved medical treatments, medicinal specifically, for female sexual arousal or orgasm disorders? Oh, you guys are so good. All of you who answered 2 are totally wrong. There are 2 FDA-approved products for libido in premenopausal women. 0 is the correct answer. It is totally and completely 0. There are 0 FDA-approved treatments for orgasm. So we are going to stop there. Stop share. And let's do questions, because I want to make sure y'all have time, that you feel heard and I can answer. And just thank you for inviting me. And this is so very cool that you all showed up. I know I keep saying that, so I'm going to stop and try to play it cool.
Yeah, thank you, Dr. Rubin. You guys can drop questions in the chat, or honestly, feel free to just turn on your video or don't and just talk to Dr. Rubin out loud. That's totally fine too. Absolutely welcome.
All right, we got a question about nerve damage and vibrator use. Steph, we really don't see it. There's really no data to support that. There's a lot of people who are worried about it. Oh, if I get used to my vibrator, I won't be used to my partner. And if you love your partner's touch and you don't want a vibrator, then that's fine. But the idea that you're like waiting for some magical orgasm to happen that your partner gives you, when there's like a perfectly good device like right there that can be incorporated into your like in like happiness, like why would you deny yourself happiness so that your partner can feel good about like being the one to give you that? My brain doesn't really work that well for my brain. And so I understand it, but there's no data at all anywhere to support nerve damage or reliance on. And I'm a big believer in like do things differently, right? Do you go on the same vacations every time you have a vacation? Do you eat at the same restaurants? Do you go to the same movie every single time? Like, mix it up a little bit. Like, there is no reason sex has to look the same every single time that you have it. Hold on, you're going too fast, guys.
Hi,
50
Dr. Rubin, I actually have a question.
Please.
My name is Cassandra. I'm from downstate in New York City.
Yeah.
And I actually had a couple of patients recently at a clinic that I'm volunteering at that expressed like general distaste with fetishes that they were aware that they had. And I don't know if this necessarily falls under one of your expertise, but I'm wondering how you would advise a patient who kind of knew what they needed fetish wise, I think, but then were kind of hesitant to engage in that aspect to achieve orgasm and were almost kind of seeking like a cure for it kind of thing, where they kind of knew what they needed, but then were looking for other kind of routes to kind of get there.
You know, there's a great book by Justin Lemeler, that called Tell Me What You Want. It's all about fetishes. It's actually a very interesting book where he asked a bajillion people on the internet what they're interested, what their likes and dislikes are. And it's fascinating to kind of look at it. And he spoke at Ipswich, so it's another reason to get involved in Ipswich. And I was on his podcast, which is really good too. It's a good podcast, but it's a fascinating fetish, like the idea that like everyone has all these fetishes and fetish isn't that like, or like fantasies, if you will, right? Like, and you don't always have to play into your fantasies, and people spend a lot of time hating themselves because of their fantasies when you don't realize that some of your fantasies are just normal. Now that's, again, I can't speak to the specific patient and what the issue was. The sex therapy is always the right answer, right? Like my job is like easy compared to what sex therapists and pelvic floor physical therapists have to do. Like, I just shuffle patients to each of them because, you know, it's all biopsychosocial. Like, you don't have to be the one to fix all of the things, but you have to hear them, listen, and then help build that team. And you become more effective team builder if you're like, hey, go see Jen down the street or Pani down the street, or go see that person who I know, here's their phone number, as opposed to go find someone who's going to fix your thing. Right. And so I don't have a great answer for you on that one, other than, you know, getting that team involved to figure out what are the underlying issues that are so upsetting. And is it really a problem? I had a patient actually who couldn't look me in the eye. The first time he came to my office, he could not look me in the eye. He was just very flat. He was very depressed. He was miserable. And it turned out that, and he was having erection issues, young guy. And it turned out that he really was interested in being a sub. Okay. He wanted to be dominated. And this was his thing. He really wanted it. Every girlfriend he found was totally weirded out by it. Like, not like, just really uncomfortable. And so I was like, listen, like, this is what interests you. There's a community who is interested in doing this. Like, it is not like what the people you are finding are not interested in these things. And so he had the sex therapist who got him knowledgeable about the BDSM community in our local area, which was very active. And he started going to events and meeting people. And he came to me, and at the end, like, he was just looking me in the eye. He was so friendly. He had passed the LSAT. His like depression had lifted because he stopped hating himself, and he stopped thinking that he was damaged and wrong and horrible. He found his people, right? And as long as you're consenting and safe and you're not hurting anyone, and like, then like, find your people, right? Like, there are people who are like freaking, there's like dating websites for like people who have like work as farmers, right? Or like people who have like, or lefties or something, like my weird kids. I've got 2 lefties. I mentioned 15-minute appointments. What do you feel the system doesn't give you? What do you do if you feel the system doesn't give you the time to ask? So Jonathan, if I had an answer to that, I would be a better doctor than I am, because I left the system. I can't do it. And I do work at the VA 1 day a week. So I take care of veterans. And if you ever are with me on a Wednesday when I'm at the VA, I am always missing lunch and I am always running late. And it's horrible. And the patients just wait for me, because I'm not willing to like do it. It's ministry, and I'm just not willing to like not do that. In my private practice that I own, I spend an hour with people. I take as much time as I need. Unfortunately, they do pay for it. And hopefully when Mark Cuban gives me a fellowship, I haven't asked him yet, but I really want to, like, just give me a little money, like just make it so that everyone can come to me for free. And like, then I can train all of you, and then like we can make the world a better place. So if Mark Mark Cuban is listening, please send us money. It's hard. So I spend time with people because that's the thing that I can give. And so I've had to go out of the system to do it, which is not a nice thing to say, but it's the only way I've been able to personally make it work for me. And what I'm already burnt out doing that. And so I don't know how real doctors do it in their 30 patients a day. And I would say making short, like repeat visits, right? And having them come back and not trying to do it all at once is the best I can tell you. Tips for anorgasmia with people with spinal cord injuries. Women with spinal cord injuries can still orgasm. Actually, it's Barry Kamazurek who did this work as well. They put vibrators inside people with spinal cord injuries, and it's because of that vagus nerve innervation of the cervix that you can still orgasm potentially. And so it's pretty fascinating work. Vibrators. It's always, the answer is always vibrators. And making sure, especially in MS, really important in MS to treat the genitourinary syndrome of menopause. There is a very under treatment of hormonal changes that happen in MS, and everyone just says this is all MS. And I have had incredible success in hormonally treating MS patients and getting them back to orgasm. I can think of one patient in particular. I loved this patient. She was a 65-year-old woman with MS who was single. She lived alone. She had no partner. She loved having her own orgasms. It was just her thing. Of course she did, because why wouldn't she? And she lost her ability to orgasm. And she found me and said, Rubin, you got to help. I was so excited. I was like, you give me hope for the world that you are here. And we fixed her hormonally from her genitourinary syndrome of menopause. We added a few medications. She had great orgasms. She lived happily ever after. And it was a very awesome success story. Impact of trauma on orgasms. Listen, there's, how could there not, right? How could there not? But it's not. The answer with trauma is in the eye of the beholder. How does the trauma affect the person's orgasms? Does it affect their brain and their brain's inability to relax enough to experience the pleasure? Does it affect their pelvic floor muscles, which are so tight, so now that they can't build up and release? Does it prevent the person from being comfortable with anyone touching the clitoris or being near the clitoris? So it's not enough to just say trauma. You have to try to let patients guide you on how their trauma affects them. Because I don't believe like trauma is like a checkbox, yes or no. There are people who have had horrific trauma stories. Like you hear the worst stories you could ever imagine. And they have great sex and great sex lives and great orgasms. And that's part of their coping mechanism. And there are people who've had one bad speculum exam and like, boom, done. Everything's off, done. No, thank you. Right? I've seen it all. I've seen both of those things. And does that make one person's trauma like real trauma and the other person's fake? Like it's trauma, right? Like, and how do you, so it's a hard one because trauma is not all the same thing. And the person who experiences the trauma is not all the same thing. Oh, Meredith Wasserman, I just love you so much. She is, oh my gosh, doing amazing things. What percentages of the patients you see are undereducated on how to orgasm versus a true physical problem? Gretchen, it's a great question. We need that data. And the answer is, I see it a lot. I see people who come in and say, Rubin, I can't orgasm because with penetration, so I'm broken. And that's like, oh yes, an easy one. Like, come on, let's educate, let's teach. And the most fun parts of my job is when I literally do what I just did with you and I throw out PowerPoint presentations and we go through it step by step. I don't change my PowerPoints for doctors, med students, patients, like y'all don't know shit, right? And like we go basic, we go step by step, and like it's so fun for them. I show these pictures to my 77-year-old veterans who are sitting there asking for penile implants. And I was like, you sure you want a penile implant? Like, it's not going to make her have more orgasms because of X, Y, and Z. And they look at me and they're like, why did nobody tell me this? I've had these old men skipping out of my office, like on their way to the stores, which I give them the name of the stores to go to find the devices because they have words and they have knowledge and they're so grateful for the most part. Do you know anyone doing research on orgasms in queer relationships or in poly relationships? Certainly there's always research going on. There is specifically like projects that are actively going on. I don't know of any specifically. I know that Case Western is doing a study right now on anorgasmia. So if none of you can have an orgasm, you should sign in to take, it's a mindfulness-based study. I don't believe that, I'm sure it has nothing to do with sexual orientation or gender. So you could probably sign up for it. It's like, I think a 6-week mindfulness activity, and they're trying to see if they can help with primary anorgasmia. So we are going to do a social media post about that this week. So it's on my list of things to do. So if you don't see it, you should see it soon. If you all want to sign up for, we have a weekly newsletter we've been trying to send out from my website. It's a lot of local stuff, but rachelrubinmd.com. And you all have to follow me on Instagram because my dream is to get to 10,000 followers and I'm not there yet. And so you have to help me. What is my typical workup for anorgasmia? I have a patient with lifelong anorgasmia and have nowhere to start. Break it down, girl. Brain, spinal cord, pelvis. What is going on with each? Like follow the story, use the story to guide you and to say, okay, are we not trying the right? These are challenging patients. I won't pretend like I see these patients and I am just like successful all the time. Hardly. It is figuring out, teaching them their own anatomy, teaching how orgasm works, teaching them that there's many ways to have an orgasm and that sometimes you just have to find the right way for you and get them excited to explore as opposed to thinking it's a chore. So there's a lot of things. There's a lot of books. OMGS is a great resource online. That's Debbie Herbenik's group has done that. That's a great thing. Teaching them about devices is a really great thing, but then also understanding, is there pelvic floor issues, getting your pelvic floor physical therapist involved to help you. For individuals who may have experienced sexual trauma, how do you approach these topics? Well, I will tell you that anyone who comes to see me knows that they're going to be talking about sexual health. So it's a little different. Like if you're just in a general clinic and you're in a primary care doctor's office and you're asking questions, it's a little different than when you come to see the sex doctor to help with your sex problems. So I understand that I'm a little bit of a unique bird. The way I treat trauma is very interesting. When I talk to patients, and I don't know there's a trauma history, or all patients, my intake is, tell me your story. And then I just let them talk for as long as they want. And I just take notes and I type and I type and I type. And then I know we have to get off soon. And then I ask past medical history, surgical history, meds, allergies, social history, family history. And then I ask them specifically about libido, orgasm, arousal, pain. And then I go into like body image issues, cultural issues, partner issues, bowel issues. I have like a whole list. And it's the last question that I ask, and I've tailored this over time, but for every patient I ever see, my last question, and sometimes traumas come up already, but I always ask this and I say, ma'am or sir, or whoever it is, I ask everyone the same question, no matter who comes to see me, I ask it the same way. And if your answer is no, no problem. Is there anything else you want to tell me, either cultural, religious, or trauma related that hasn't come up yet that you want me to know about? And it's really powerful because it tells the patient that if there is, you don't have to tell me. But the door's open, right? Like I am genuinely interested, but I'm also not going to assume that every piece of trauma explains your whole story. Because you can talk to someone right? They can choose to not bring up the trauma. And in that case, that's their choice. And that's not like, I don't have to know that. Does that make sense? All right.
Yeah. All right. Sorry to cut you off, Dr. Rubin, but we are at the end of our time. We've still got about 110 hanging on. So for those of you still here, take a screenshot of this, write it down. I'll leave it up for a few more minutes, but thank you so much, Dr. Rubin, for coming. Your enthusiasm is really what keeps us all going. You guys join the SMRT group. I put the email in there. I think I saw somebody put the sign up. Join this forum. I definitely saw the sign up in there. Join all of these Instagrams, the Facebook, the Twitter. And if you don't do any of that, at least research sexual medicine so that you can teach it to your patients regardless of what field you go into. Thank you so much, Dr. Rubin and Jen Romello.